Hi, everybody. Thanks for checking out this applied learning case. My name is Adam Kinney. I'm an occupational therapist, an investigator with the VA Rocky Mountain MIRECC for suicide prevention, and assistant professor in the Department of PM&R at the University of Colorado School of Medicine. And today we'll be talking about how we use mixed methods to understand the implementation of guideline concordant care for vets with mild traumatic brain injury. So we'll start by just giving a broad overview of mixed methods research and why we may want to use it. And then I'll move forward with talking a little bit about how we applied mixed methods research to our work in the VA. So just the standard disclaimer that this work does not necessarily represent the views of the VA or the US government. So to take a step back, just want to appreciate how complex what we're trying to study is. And what we're trying to study is the delivery of rehab in real-world clinical settings. So factors at multiple levels kind of shape this process. Factors at the patient level, the provider level, characteristics of the intervention, the clinical setting, and the broader sociopolitical context in which the clinical setting is situated. And to make matters more complex, these are not mutually exclusive factors. They're mutually reinforcing, and they change over time. They're highly dynamic. So to summarize, this is just really, really complex. And our research methods need to be capable of capturing this complexity. And I think that mixed methods research is uniquely situated to understand the complex nature of rehabilitation service delivery. It does so by combining the strengths of qualitative and quantitative approaches to achieve both a breadth and depth of understanding of our research topics. So these two approaches kind of balance each other's weaknesses out. So quantitative approaches, it's really good for identifying relationships, detecting tendencies in our data, and generalizing those relationships beyond our immediate sample. But it often lacks context and explanation for why those relationships may be occurring, exactly what is going on, and we're kind of constrained by what we measure using quantitative approaches, what items we're including. And we may neglect important stakeholder perspectives drawn from their lived experience. So on the other hand, qualitative approaches elicit this kind of information. What contextual influences are going on that may explain the findings that we're seeing? And it centers the lived experience of stakeholders, so you get this emergent information that you may not have thought of as a researcher. But results may be subject to bias and aren't generalizable. So mixed methods research kind of combines these two, and that brings me to the most important stage of this kind of research, which is synthesizing these two approaches. We don't want to just collect quantitative and qualitative data and call it a day. We want to bring them together and draw inferences based on that synthesis. And there are a few different ways that we can go about doing this. So one is the convergent parallel design. So this is when you collect and analyze quantitative and qualitative data at the same relative stage of the research process, merge those findings together, compare and contrast, see how they align, see how they don't, and draw inferences about how those comparisons, draw inferences based on what those comparisons are telling you to understand your topic a little bit better. Then there are a few designs that have a particular sequence to them. So the explanatory sequential design is when you begin with quantitative data collection and analysis, and you use qualitative data to explain those findings, not only what relationships you're detecting, but why those relationships may be occurring. And you bring those together and draw inferences about your topic. And lastly, there is what is called an exploratory sequential design. So this is when you begin with qualitative data, you use those results to develop or contribute an understanding of a quantitative measure or other clinical innovation like an intervention. Then you again use quantitative data to test that measure or innovation and draw inferences again. So the classic example of this is you interview stakeholders to develop items for some measure of a construct that you're interested in. Then you subject that measure to rigorous psychometric evaluation to verify that it's measuring the construct that you want it to, and then implement it in whatever setting is appropriate. So now moving on to how we have applied some of these concepts, and specifically we conducted a convergent parallel design. So mild traumatic brain injury is highly prevalent among post 9/11 veterans. It's often referred to as one of the signature injuries of the conflict. And more often than not, symptoms resolve after the initial injury event, but a substantial portion of our service members experience symptoms long after the initial event. And in particular, sleep disturbance and headaches are among the most common and disabling of these symptoms. So to guide the clinical management of sleep disturbance and headache, the VA and DoD developed the Clinical Practice Guideline for Mild Traumatic Brain Injury, releasing it in 2016. And based on a systematic review of evidence and clinical expertise, interventions for both sleep disturbance and headache fall into three major buckets. First, psychoeducation, so lifestyle changes that may help improve these symptoms. Non-pharmacologic interventions, things like cognitive behavioral therapy, and medications to improve sleep and reduce headache. So I just want to point out that there are separate recommendations for each of these symptoms, just for the sake of being concise and fitting this on a slide. I group sleep disturbance and headache together, but there are a little bit, still the same major buckets, but the specific interventions are a little bit different. And each of these interventions have been assigned the same strength of recommendation, a weak recommendation in favor of their implementation in real world care based on evidence that they reduce post-concussive symptoms and disability. Now, despite the fact that these interventions are recommended by this practice guideline based on evidence, we know little about the extent to which they're actually being implemented in real world care. And really important, we know little about what implementation determinants may be shaping whether their providers are actually delivering guideline adherent care. And this is really important because the VA and DoD just released an updated version of this guideline in 2021. And so we can apply lessons learned from the release of the 2016 guideline to future efforts aimed at promoting the implementation of recommendations within this new guideline and making sure our veterans receive evidence-based and patient-centered care. So that was our purpose for this particular study, to understand the barriers and facilitators to implementing recommended practices for post-concussive sleep disturbance and headache in the VA. So again, we used a convergent parallel mixed methods design. We're able to recruit 20 VA stakeholders, who I'll tell you a little bit more about in the coming slides. For the quantitative strand, we used an electronic survey asking stakeholders to rate each recommendation within the CPG using the LeaRRn instrument that I'll talk to you about in the next slide. And we used a descriptive analysis of each LeaRRn item for each recommendation. For the qualitative strand, we conducted 17 individual semi-structured interviews and used descriptive interpretive approach to analysis. And the most important stage of this inquiry was synthesizing the findings from these two approaches. And to do so, we used a joint display table that kind of grouped the quantitative and qualitative results side by side, enabling easy comparisons and enabling us to draw meta-inferences. And we grouped these meta-inferences in three broad categories. First, confirmation. This is when the quantitative and qualitative results corroborated one another. Expansion is when the qualitative results aligned with the quantitative results, but just gave a little bit more nuance, some more specific emergent information that kind of helped us understand exactly what was going on. And then emergent information was when the qualitative results elicited important information that was not captured using the LeaRRn instrument. So a little bit about the LeaRRn. It's a psychometrically sound assessment of clinical practice guideline characteristics that tend to influence its implementation in real-world care. It's designed to be rated by a variety of stakeholders, and there are 9 items rated on a scale of 1 to 7, with 7 being the highest quality. These 9 items span 3 domains. Clinical applicability. This is the extent to which the recommendations are relevant to the needs of target users. Values is the extent to which the recommendations align with the values and preferences of relevant stakeholders. And implementability is the extent to which the recommendations are suitable for the local clinical context. So to develop our interview guide for the qualitative portion, we used the Consolidated Framework for Implementation Research, or CFIR, interview guide tool. So for those of you who aren't familiar, the CFIR is one of the most widely used implementation determinant frameworks, based on a synthesis of a huge amount of literature. They generated 39 constructs that serve as barriers or facilitators to implementation outcomes. And those 39 constructs fit within 5 broad domains: intervention characteristics, so characteristics or attributes of the intervention itself; the outer setting, or the socio-political context in which the inner setting or the specific clinical context in which the implementation effort is occurring; and then individual characteristics are attributes of those who are involved in the implementation process. And the implementation process is the formal efforts by which an intervention or other clinical innovation is introduced into the clinical context. So just a little bit of a side note, the CFIR has been updated recently to CFIR 2.0, so I'd encourage you to check that out. And I would also encourage you to use this interview guide tool in your own work. It's a really great jumping off point. So what you do is you choose the CFIR constructs that you think are most relevant to your area of study, and it generates potential interview questions for you based on those constructs. So I wouldn't recommend just using those recommendations verbatim. I think it's important that you tweak them to your specific needs, but I found it really, really helpful for someone who's relatively new to this area of research to kind of at least get a starting point. And you should be able to locate the interview guide tool in the resources section of this case. A little bit about our sample of stakeholders. We were able to gather information from a variety of disciplines, 7 of whom were physicians, 4 neuropsychologists, and 3 OTs, PTs. Most described their primary professional role as clinical providers and had at least 11 years of experience managing mild TBI, so a lot of rich clinical experience from which we were able to draw to understand the implementation of these recommendations. So I know we said we had a joint display table that we used, but that was a little bit hard to capture in a PowerPoint presentation. So in a few slides, I'll be giving you a reference to our published study where you can find the joint display table. For the purposes of this presentation, I'll be kind of visualizing the quantitative data and describing the qualitative themes side by side and talking about how they relate. So the visual here is, on the x-axis, you'll find relevant agree-RECs items. On the y-axis is the rating of their quality as perceived by stakeholders. The red box plots are ratings for the headache recommendations, and the blue box plots are scores for the sleep disturbance recommendations. So to start, there were several characteristics of the clinical practice guideline that were corroborated and consistent across both qualitative and quantitative findings. So to summarize, stakeholders perceived the clinical practice guideline to be a high quality product and one that should serve as the standard of care for detecting and managing mild traumatic brain injury in the VA, in part due to its rigorous development process, not only drawing from peer-reviewed evidence, but also drawing from direct clinical experience. In particular, stakeholders also called out how important it was that the guideline recommended that providers align treatments with the individualized needs of the veteran. So it was really in alignment with veteran preferences and really suitable to their needs. The strength of the evidence underlying the recommendations was also identified as something that facilitated the implementation of these recommendations. But the qualitative data gave us a little bit more nuance around exactly what was going on. And in particular, if you remember those 3 buckets, education, non-pharmacologic treatment, and medications, they were all assigned the same strength of recommendation, but stakeholders pointed out that those 3 buckets have varying levels of evidence in their favor. And maybe a provider needs to take that into account when recommending a treatment, and so that can affect the implementation of certain recommended treatments in the guideline. So as one provider said, so I guess I would prioritize those practices that have repeatedly shown positive effects. If there are practices that the literature is somewhat ambivalent about, where half the studies you find positive effects, maybe half the studies you find no effects, or perhaps even negative effects, then that should be lower on the list of recommended practices. The design of the CPG also emerged as a factor influencing implementation in the qualitative data, but was absent from the quantitative approach. So specifically, the length of the CPG was identified as something that made it difficult to use the CPG at the point of care and undermined its implementation. As one provider said, I think it's just making it easy and accessible for the frontline provider or the end user to have it accessible. To make it small, compact, and easy to use is probably the most important thing to get use out of the CPG. So both the quantitative and qualitative approaches identified that the recommendations were consistent with implementation priorities in the VA clinical settings. But again, the qualitative data gave us a more nuanced depiction of this. In particular, stakeholders identified a lack of comprehensive and systematic efforts targeting implementation. So they often referenced webinars that drew awareness to the presence of the practice guideline, but there's no systematic, system-wide approach to identifying and mitigating barriers to providers implementing these in real-world care. One thing that clinicians pointed to that helped facilitate the implementation of the guideline was serving as informal champions. So often they would reference the guidelines and corresponding evidence in interdisciplinary meetings, advocating for the use of the guideline and advocating for adherence to its recommendations. There were several clinician-level factors that emerged in the qualitative interviews, but were absent from the quantitative approach. So first, provider knowledge of their awareness of the recommended practices. So as one provider said, so what I'm thinking of is like primary care. It's fast, they get a lot of patients, and some of our primary care docs do have a lot of knowledge about things like mTBI, but a lot of them, of course, don't. So I think a lot of providers aren't aware that there's even a CPG that exists. Similarly, provider self-efficacy or their confidence in their ability to deliver a particular treatment also influence implementation. As one provider said, if they don't have an understanding of what that means, then I don't know that they can be very confident in implementing that or in delivering that care to a patient or even recommending it. So the quantitative and qualitative approaches both revealed that the recommendations were suitable for implementation in VA clinical contexts. They aligned with the clinical priorities and the characteristics of the facility in a way that made it easy to implement the recommendations. But the qualitative interviews gave a better sense of the specific forces at play that kind of affected that alignment. So specifically, facility culture. Stakeholders said repeatedly that a shared belief in the importance of evidence-based and patient-centered care helped facilitate the implementation of these recommendations. In addition, the resources of the facility, in particular, the time that providers have available with patients, and the supply of specialty care providers that deliver certain recommended treatments like cognitive behavioral therapy, were really important factors influencing implementation. Interestingly, stakeholders pointed out that these weren't necessarily mutually exclusive, right? That they interacted in ways that influenced the uptake of recommendations. So you could have a facility that have this shared belief in evidence-based practice, but if you don't have the resources to enable the delivery of that care, then the positive influence of culture on the uptake of these recommendations is not realized. And lastly, stakeholders pointed out a few strategies that could be used to promote the uptake of these recommendations in the qualitative interviews, and again, weren't available in the MIRECC items. So they mentioned decision support, so finding ways to augment that clinical encounter in a way that gives providers and patients access to recommended treatments at the point of care. Patient-facing educational materials, so veterans can get a sense of what intervention aligns more or less with their individualized needs, and performance measurement. So finding ways to evaluate care processes using medical record data or other data sources to evaluate adherence to these recommended treatments, and finding ways to incentivize greater and greater adherence at either the provider or clinical level. So to wrap up, stakeholders perceived that the clinical practice guideline included features that reflect priorities in the VA and that it should be used as a standard of care for managing mild traumatic brain injury, and this really helped facilitate its implementation. Now, if we were only using the agree recs, I think our conclusion slide would stop right there. The agree recs really gave us a sense that in general, providers rated the recommendations of high quality, but the qualitative data helped complement that information by highlighting multi-level barriers to the implementation of these recommendations, and these were specific in nature and served as targets for potential strategies to improve the uptake of these recommendations. In particular, we're using this information regarding the design of the CPG, provider and facility level factors, and the lack of a systematic implementation process. We're using that information to develop a decision support system that uses raw medical record data to provide recommendations for treatment at the point of care so that providers and veterans can collaborate together and identify a treatment recommendation that is both evidence-based and consistent with the preferences of the veteran. So without mixed methods research, we wouldn't have been able to leverage the complementary strengths of both quantitative and qualitative research, and we wouldn't have achieved such a comprehensive and holistic understanding of what made it hard to implement these recommendations. And I think, the impact of our efforts aimed at promoting the quality of care for these veterans would have suffered as a result. So I can't say enough how important it is to use mixed methods research in this space, and I hope this was somewhat helpful in your work as well. And just want to end with a shameless plug. Please find our published study in the archives of PM&R if you'd like more details, and you can also find my contact information if you look that study up. And I'm always happy to chat about this study or mixed methods research in general. Thank you so much for your attention to this applied learning case, and hope to talk to you soon.